two separate pieces of research today. The first was a case study of one high-cost private residential home for older people that I've named Oakwood. And this piece of research took place pre-pandemic, and it involved observing and taking part in the company's recruitment training, as well as undertaking interviews with both new recruits to the care home and experienced care workers. So the focus of the first study was on care workers' emotional enrolment in the caregiving role, and on how care workers were encouraged to view their work, and also on considering what consequences these things had for care workers. And the second study that I'm going to talk about, which kind of feeds from this first study in some ways, is an ongoing piece of research, as Paul mentioned, on paid care work during the pandemic, which has involved undertaking telephone interviews with care workers who work in care homes and also in home care. And the focus of this piece of research has been on how COVID-19 guidelines has changed the work that care workers do, and also in particular on the close and intimate aspects of care work, and on the relationships that care workers develop with the older people who they provide care to. So my focus today is going to be on data gathered in interviews with care workers who work in care homes rather than home care. So just starting with the first study, the business of care. This study had two kind of motivating factors that caused me to undertake it. So the first was that there were concerns about poor quality care in care homes, which at the time were resulting in calls for more compassionate, more caring care workers who would be subject to more training and more regulation. And the second was Ali Hochschild's book, The Managed Heart, in which she wrote about a concept called emotional labour. And she basically used the term emotional labour to describe instances where workers were expected to manage and regulate their expressions and their feelings in order to fulfill the emotional requirements of their job. So, for example, she looked at how flight attendants were expected to put on a smile to make their customers feel good, and they were asked to suppress any feelings of annoyance or upset if customers were rude or if they behaved inappropriately. And she looked at the emotional consequences for workers when their employers came to excessively manage their emotions and feelings in the workplace. So I used the concept of emotional labour to look at how care workers were taught to view their work and how they were taught to manage and express their feelings and emotions. And one key finding of that study was that the care home in question, Oakwood, repeatedly described the emotional labour of its care workers as something which came naturally to them. So, for example, in a handbook that was given to all new care workers, the company described its care workers as truly unique. It said that they were born to care, that they had natural serving hearts, and that they all had this belief that real happiness and joy came from serving others. So the language that they used was very much, it kind of described the care workers as naturally very caring people that they had kind of sought out in the community and recruited. And then in the interviews that I undertook with care workers, each of the recruits also described that kind of altruism as an integral part of their nature that they were used to acting upon in private settings rather than as a work-based skill or something that they'd been taught. So, for example, when asked if she felt that her induction training had caused her to be more caring, Irina said, "I think that I've already got that in me. If you ask my family, what are my qualities? Then they say I'm very caring, I'm very loving and nurturing. I think I have it naturally within me. So it's not something I really think about." So Oakwood not only defined the care workers' emotional labour as natural, it also defined their work as something that could be naturally rewarded. So in a video that new recruits were shown in their training, the CEO referred to hugs from residents and thank yous from residents' families as a second paycheck. And here they implied that workers who acted upon their kind of natural altruistic motivations would find their work satisfying in its own right, rather than because of any financial reward or benefits that they might receive from the company. And the care workers also seemed to view their work in a similar way. So, for example, when asked what job she would do if she could pick anything at all, Pat said, "I think it would be care because of what you get out of it as well as what you can give." It's kind of got that double whammy, hasn't it? It's a career and you've got that job satisfaction as well. But one potential consequence of a worker's care activities being defined as natural is that the work that those activities entail can be erased, and this in turn can devalue care work economically. And this was perhaps why, quite surprisingly to me at the time, all of the care workers who I interviewed as part of the study said that their wage was reasonable despite being paid minimum wage. And the care workers also tended to appraise their work performance in terms of whether they'd been able to gain a sense of personal worth from residents or from residents' families, rather than any other financial or economic benefit. They basically evaluated their work in terms of whether they'd received this second paycheck that the company spoke of. So by evaluating their work in this way, care workers also seemed to have developed a tendency to give of themselves voluntarily. So, for example, when asked to describe times that they'd done a good job, all of the experienced care workers gave examples of where residents had been thankful for them staying after work, or what times when they'd gone beyond their official job descriptions. So Pierre gave the example of doing more work than what he was told to do by staying after work to provide end-of-life care, and thinking to himself, this is my parent or my relative, and how would I like them to receive this care? So the care workers' voluntary acts and this kind of giving of themselves beyond their job descriptions often arose from their close relationships with older people. And these relationships were often described by the care workers as family-like. And then similarly, in the training of care workers, the trainer spoke about the importance of care workers treating residents as if they were family members. They repeatedly stressed it. So the trainer would say things like, act as though this is your mother, treat the residents as though they're your own parents or grandparents. But then providing this kind of care often meant that care workers, like Pierre, ended up working unpaid overtime. And it also meant that there were some deeper emotional costs for the care workers, which often became apparent when care workers spoke about times that they provided end-of-life care to residents. So Sarah, for example, said, when Pearl died, I cried all day non-stop, like it was my granddad. I came home and I cried. I cried before she died, seeing her crying, going home crying. That felt like it was a family member. Sometimes I've really cried for a resident. So many of the care workers had come to take part in the caregiving role, not only as if residents were close family members. The relationships had become kind of wholly authentic, and this did leave them at risk of becoming distressed when residents suffered or died. So to briefly summarise this previous study before I move on to the current study, a key finding was that care workers, with the encouragement of the care home's management and trainers, viewed the work that they put into managing their emotions at work as something which came naturally. They were also encouraged to view residents as family members and to be satisfied with emotional rewards for their work, like hugs and thank yous, rather than higher wages or employment benefits. And this had consequences both in terms of care workers giving up their time voluntarily, not really fighting for better work conditions, but also it meant that they were susceptible to becoming emotionally over-involved in their work or emotionally exhausted. So, of course, a lot has changed since that's and the care home sector has been under a lot of different pressures during the pandemic. And that's because care homes, as we all know, have been identified as places where extra measures have been needed to prevent the spread of COVID-19. So that includes wearing personal protective equipment like masks and gloves and visors, social distancing, but also other measures like repeated testing, banning visitors to care homes, cancelling social activities, closing communal spaces. And in other cases, and in certain care homes, care workers have been asked to live on site or to work in different shift patterns so that they're kind of limiting their outside contacts. And initial research suggests that during the pandemic, care workers have felt stressed, vulnerable, overworked, anxious about infection, and that they've sometimes found they've encountered a lot of challenges in trying to keep older people safe. And more recently, there's also evidence from Skills for Care that existing problems with recruitment and retention in the sector have been made worse, particularly since the end of the initial COVID-19 lockdown in England. So my own study focuses on care workers' experiences of working in care homes and home care during the pandemic, and on the close and intimate aspects of caregiving and relationships between care workers and older people living in care homes. And today I'm focusing just on the case of care homes rather than home care. So to go back to some of the topics of that previous piece of research, just summarise, care workers in this study so far, because it is ongoing, have said that family-like care is really important to them. So there's a similar emphasis on the importance of family-like care as there was in the previous study. And this has often been when I've asked care workers to describe what good care means to them. So for example, Millie said, good care is treating people as though they're your own mother and doing things that matter to the individual. It's giving them that home that they need. And many care workers described physical closeness or touch as important aspects of this kind of care and as part of what made those relationships family-like. So for example, Neve said, if you have a good relationship, sometimes they'd like a little hug and a little touch of the hand, and a lot of that stopped. And it was quite sad because they're like your family, aren't they, in the end? That's lovely, isn't it? When you see your kids and you give them a big squeeze. We had to switch off from that. So some care workers described that the care that they provided now and during the pandemic was exactly the same as it was pre-pandemic, which I was quite surprised about. So they said the only difference was that there'd been the addition of masks. But for most care workers, like Neve, I was told that social distancing rules had an impact on the kind of care that they were able to provide and on their relationships with older people. And many care workers said that it had an impact, those guidelines had an impact on whether they were able to provide what they considered as good care. So Jordan, for example, said, normally I'd probably sit very close to somebody and offer quite a lot of touch, even if it was just a stroke of hand or arm. So certainly at the beginning, everyone was very cautious about doing that and didn't want to get too close to an individual because it was putting them at such risk. And that closeness definitely did stop. So Jordan said that this was particularly the case if someone was isolating, saying carers will go in and do the task, but that's it. There's not a lot of room for, any sort of nicety to go with that. And care workers gave lots of examples of these niceties, like smiling, hugging and chatting. And they also spoke about bigger events and activities, which they felt had helped to create positive relationships with residents and their families pre-pandemic, such as sharing meals together, activities and day trips, as well as care workers being encouraged to bring their children into work in a number of cases. So Keisha said that there was now much more of a distinction between residents and staff as she had to do her job and then move away. So here her job was seen as the kind of physical rather than emotional aspects of care. And she said that whilst residents still received basic care, the emotional or social side was sometimes compromised, saying you'd have a different relationship generally with the individuals and their families pre-pandemic. People seemed more involved, there'd be a lot more joking, whereas it seems now there's a much more us and them mentality. I think families are still a bit annoyed that they can't come in. And she compared this to kind of other sectors in the NHS where rules were perhaps more lenient now. And then Sarah also spoke about the lack of physical contact, which she now had with residents, saying obviously before COVID we would have hugs and things like that with the residents, but because of COVID we weren't really allowed to. We haven't really hugged them, which is quite sad. as well as talking about the impact which social distancing has had on the kind of care they're able to provide. Almost every care worker that I've spoken to as part of the project so far has spoken about the impact which problems of short staffing has had on their ability to provide the kind of care that they would like to. So Valerie, for example, said that while what she called residents' basic care needs were being met, any extra quality or attention to detail had sometimes been harder to provide because of short staffing. And these extra details or emotion-based interactions were the things that care workers considered to be part of good care. And they also formed a large part of the emotionally rewarding parts of care, which in the previous study was what was encouraging care workers to sort of stay in their job and feel rewarded in their work. So when asked what care homes could do to reduce problems of short staffing caused by care workers leaving their jobs, Valerie said, maybe they could have given their staff more incentives to sort of stay in the beginning, not necessarily monetary, but some chocolates or whatever, just a little gesture to thank you for everything. Because the carers are the bread and butter of the service. You don't have a care company without your care staff. The first day, claps for carers, don't get me wrong, that was lovely, but from the community. But it just, again, I'm going back to Boris, and again, he can shove his claps where, you know, somewhere else. And similar sentiments to this were expressed by other care workers, and many spoke about the distinction that they felt between how care home staff and NHS staff were regarded by politicians and by the general public throughout the pandemic. And this is something that's coming out of wider research on social care as well. So many spoke about how NHS workers were seen as heroes, whereas those working in care homes were treated like what one care worker called second-class citizens. And unlike in my previous study, where care workers had rarely mentioned their pay packets, several care workers have spoken to me about the low wages that they receive, and they've described them as representative of a general lack of respect for and recognition of care workers. A number of care workers have also spoken about the impact which the pandemic has had on their own mental and physical health. So Ishmael, for example, said some residents have died, some have become terminally ill or had an impact on their mental health. And it's also had an impact on my own mental health, where the care home haven't supported me sufficiently. And Ishmael said that he felt that he'd put his own health at risk to support residents. And later in the interview, he said that he had considered leaving his job because although it did allow him to feel like he was making a difference, he didn't feel like this difference was rewarded in any way by his employers. And then Keisha spoke about the wider impact of the pandemic and COVID-19 guidelines on staff morale, saying the pandemic has generally affected staff morale. Everyone's quite drained, people don't want to do anything extra. Whereas previously, staff would have, if we had someone who was dying and there wasn't a family member there, people would volunteer to sit with them, like Pierre did in the previous study. But if someone was off sick, you'd be quite willing to cover for somebody else. And now people are just fed up. Several care workers said that they'd considered leaving their jobs and were actively looking for employment outside of the care sector. They described feeling under constant pressure and stress, their low pay, and the unfair demands made of them for their reasons for leaving. Sarah, for example, said that she doubted whether she'd stay working in social care through the pandemic, and that the lack of appreciation which care home workers had received had left them asking, what are we doing staying in this job? So just to reflect on some of the unfortunately quite bleak findings of particularly the study that I'm undertaking at the moment, but to think about the two studies together, it seems that many care workers still view the work that they do in terms of this family model of caregiving. And they still tend to judge whether they've done a good job in terms of whether they're able to provide care as though residents are their family members. And to be clear, I don't want to suggest that paid caregiving should be wholly devoid of emotion or completely impersonal, but we know from the previous study that asking care workers to care for 20 or 30 fictitious family members isn't something that's ethical or sustainable. And what early findings from the second study indicate is that the family model of caregiving in some care homes at least seems to have reached its limits during the pandemic. So social distancing, a lack of physical contact, short staffing and high turnover of care home residents have all had an impact on care workers' ability to develop the kind of relationships that the family model encourages. And these things have also meant that care workers are less likely to receive what Oakwood, the care home in the previous study, called the second paycheck. So many are no longer able to hug residents. They have minimal contact with residents' families. And many of the care workers also felt that the additional sacrifices that they'd made during the pandemic, sometimes not seeing their own children for weeks or moving into the care homes where they worked, were not recognised or rewarded with gratitude or in terms of better wages. And so it's perhaps unsurprising that some of the staffing problems which the care home sector faced pre-pandemic have been made worse over the last 2 years. And before finishing, I just wanted to reflect on why this should sort of matter to all of us. So hopefully, I do like to think that we'd all like care workers to be granted decent working conditions, regardless of what the kind of knock-on effects of those good working conditions are. But there's also increasing evidence that good quality work conditions for care workers means good quality care provision for older people. And positive non-exploitative care relationships mean better experiences for everyone, and much less likelihood that care workers will be burnt out and leave their jobs, leading to further short staffing. So we need to kind of break that cycle. But staffing crises in care homes are also having an impact on the number of care home spaces available to older people. So there are lots of examples of care homes sort of reducing the number of spaces they have. And this is at a time when we should be maintaining and expanding the choices that are available for people in need of care, rather than limiting those choices. So what are some of the things that we can do to try and improve this? Well, there's lots of focus at the moment on trying to recruit care workers into the care homes and home care sectors. And you might have come across radio or TV adverts promoting care jobs. And this is great for encouraging people to join the sector. However, we need to make sure that we also are improving work conditions at the same time. So we're not falsely advertising and encouraging people into jobs where they realise a couple of days in that it's not actually right for them and it's not what's been sold. And this research also suggests that we need to be mindful of how we encourage care workers to view the caring role, of what we ask them to do, and of when these things might be unreasonable. So we also need more ways of talking about and promoting good care that don't rest on often unrealistic ideals of family caregiving. We need different ways to think about how that relationship can be a positive one, which will hopefully be where this study ends up going. And finally, we can support care workers in their fight for better pay and conditions by signing petitions, backing campaigns like those for GMB Union, and supporting organisations like the Care Workers Charity, which provides crisis grants for care workers at the moment. That's it, thank you.
Wonderful. Thank you, Ellie. Some really fascinating findings coming through from both from your previous study and the current study. As Phoebe says, some great research. So thank you very much for giving us your time today and sharing some of your research findings. There's a few comments in the chat box, couple of questions that I'll leave you to have a read and think about, and we might come back to that after the second presentation. So we'll now move to our second presentation for today, our second and last presentation, and I'm delighted to welcome representatives from Alive, Isabel Jones and Ben Trow. And their presentation is called Care Homes in the Pandemic, Learnings and Legacy. So Isabel Jones is the CEO, Chief Executive Officer of Alive Activities, and Alive is a charity which is about improving the quality of life of older people and their carers. Alive is one of the leading services in the UK of meaningful activity for older people, providing engagement, support and training in both care homes and community settings. Their range of innovative projects and services brings art, sport, information technology, gardening, and intergenerational connections to older people and their carers. So Isabel couldn't join us today, but you can see Isabel on your screen. So Isabel kindly pre-recorded a 15-minute presentation for us today. So Isabel's going to present through this recording, and then I'm going to invite her colleague, Ben Trow. Ben is the Business Development Manager for Alive, to address questions that people might have about the great work that Alive's doing and some of the ideas and some of the examples that Isabel's going to speak to today. So first of all, we'll watch the presentation from Isabel. So thank you, Jen.
Good afternoon, everybody. My name's Isabel Jones. I'm the CEO of the charity Alive. I'm going to be talking to you a little bit this afternoon about our work over the last couple of years with care homes, how we've developed our practice, we've supported them during the really testing times that they've all faced, and how we've had some incredible moments of joy and connection and have been able to link up older people with the community that surrounds them. We're a charity and we're based in Bristol, and we work predominantly engaging older people creatively through different types of meaningful activity, whether that's sessions in care homes or in our meeting centres in the community. We support carers, paid and non-paid, to try and deliver outstanding care at every opportunity. We also believe very strongly in the power of community and try and link up older people to the community and the peoples that surround them. I'm going to talk a little bit today about our intergenerational work during COVID, how we've managed to somehow or other keep 2 intergenerational projects going and how that's developed into different practice. And then also a little bit about technology, how we've used that to harness engaging with older people and to develop new products that we're now supporting older people with. But first of all, I just wanted to apologise for not being able to be there in person today. For those of you who know me, know I'm a gig rower and I'm actually on my way to the Isles of Scilly. Hopefully the weather will be like this as part of the World Pilot Gig Championships. I'm supporting my crew in their bid to hopefully not come last in the race. Ben Trow, my colleague, who's been absolutely fundamental to a lot of the work that we do and is very aware of all the different projects, is there on hand to answer any questions you might have. So please feel free to ask away or alternatively contact the office and the details are at the end. So as an organisation, we've been doing intergenerational work now for at least 8 years. We've done various different projects and different guises, all of them about creating connections between older and younger people. We've done iPals, where we've been using technology. We've done Paint Pals, where we've been using art. And we've done gardening, where we've used nature and gardening to be able to connect older and younger people together. In 2019, we received funding from the National Lottery to be able to develop our practice, and we started running a project called Building Communities. This was a way of furthering our reach, being able to work in 3 counties that we hadn't worked before. So we had 17 partnerships where we were bringing care homes and primary schools together in different ways. We used our traditional model of intergenerational work, where we had monthly face-to-face meetings where the schools would come to the care home and exchange an hour of connection. It was facilitated by an Alive member of staff, but often the topics were chosen and co-production was really important and fundamental to the structure of those sessions. So, for example, sometimes we were doing yoga, we were doing gardening, we were doing craft making, we were doing story sharing. All the participants would choose what they wanted to do. But of course, in March 2020, in the middle of this, COVID hit. As a result, we weren't able to develop those partnerships. There was no contact at all between March and August. We saw those partnerships dwindle due to the stress down to 5. But we were able to switch online, and when schools came back in September and COVID and care homes were able to engage with a wider community. So we started using Zoom. One school also used Seesaw, which was a way of uploading work in between sessions so they could keep up the interaction. But as you can see here, we've got a group of children in their classroom and a group of older people in their sitting room, and our facilitator, who is facilitating that conversation and that engagement. The sessions lasted about an hour, if sometimes a little bit less, but we had to be really creative and plan those sessions incredibly well to make sure that everyone was engaged all the time. So we came up with quizzes and songs and all sorts of things to be able to engage. But of course, there were issues as well. There were Wi-Fi issues, but also some care homes during this time had to face lockdown, where residents actually had to then be isolated again in their rooms and weren't able to join in the group sessions. But we supported the care homes to use individual tablets in residents' rooms so they could still join in, still see the children, and actually were still able to participate and engage and not just listen. It was, as you can imagine, bringing older and younger people together on Zoom in a pandemic. You know, it was challenging. We needed to be flexible. We had to be person-centered with the topics. And I said we had to be really engaging. But what was interesting was to see that the relationships weren't as deep. They were broader. But the individual relationships that we'd often seen when people were face-to-face, whether maybe the quieter members of the class would form relationships with older people, didn't happen. It was less normally with our activity sessions with intergenerational, there's a really long-lasting effect on the well-being of older people, and this was marked that it wasn't so profound this time. But actually, on a school's point of view, it actually meant that we had more people involved. Previously, we'd run it with smaller groups when it was face-to-face, because it's a lot easier to bring 6 members of children to a care home than it is to bring a whole class. But having it online meant that you could include a whole class or a whole year group. And it made it more successful and easier for the school to be involved, and actually then increased the awareness of what was going on in care homes. We were restricted by safeguarding issues. We could have possibly looked at forming those individual engagements, but actually it wasn't practical. But we also needed to support care homes and schools to engage. So we've actually produced an online guide. So if you're interested in that, let me know, and we can send you a copy. The feedback that we had, even though it was different to how we'd run it before, was that they were very successful, that the children in particular absolutely loved it, and for the older people to be connected to the wider community was fundamental during this time. We were then approached as a result of that, or in the middle of that, to be part of the I Will project, which was run. It was run as part of the I Will, which was the Dunhill Medical Trust and National Lottery. So we were asked predominantly by My Home Life to be one of 3 organisations involved in intergenerational. And it's about creating social action. It's about creating an army of young people who know what it is to volunteer and how important it is to play that role in social action. But for us, it was about ensuring that older people had that role and that ability to help and support people around them. So we were also, because of the learnings that we'd had from the Building Connections project, we actually looked for alternative ways. So we weren't just linking up with schools, because we didn't know where we were going to go in terms of the pandemic, because this was 2020. We were also looking at youth groups and brownie groups and guide groups and scout groups to be involved. And actually, the way that the project developed, because of the subsequent lockdown in 2021, we actually got a lot of families involved. And so we saw a different type of volunteering and intergenerational work. What I'm going to do now is share a video which has been put together by My Home Life, and it's run actually by Hattie, she's been the project manager, and I think she can put it a lot better than me, actually, what's been involved in it.
Hello, my name is Harriet, and for the last 18 months I have been managing the Intergenerational Linking Project One Good Turn here in Bristol. Very early on in the project, I think there was loads and loads of support from local schools, local families and youth groups who wanted to reach out and send messages of hope to people living in care homes and say, hey, we know we can't see you at the moment, but you're very much valid members of our community. We've tried to create as many opportunities as possible to link people together across the generations to form meaningful connections and friendships, despite the challenges that COVID-19 has put in place.
Michelle, I'm Lucas and I visited Wimwell Hill City Farm with my family. The farm began as a community project in 1976. We saw a cow and its calf, some pigs sleeping in their barn, goats climbing cheekily, turkeys and some noisy geese shouting at the ducks.
Seeing older people get those messages and want to send them back into the community has been fantastic.
I'm really enjoying it and I'm really happy that I'm putting a smile on other people's face.
There we go, and I hope you agree. It's just been an absolutely fantastic project, one that we're incredibly proud of. And I don't know about you, but I always seem to well up whenever I'm watching the song with the Let It Be, and it always makes me cry. So I hope you enjoyed seeing that. Bear with me just while I'm struggling with my PowerPoint to get it up and running. It's not working at the moment, so bear with me. Here we go. There we go. Back to the right place. So I want to talk to you a little bit now about technology. Technology we've always worked with. We were one of the first people to actually use touchscreen technology with older people and could see the importance and the joy it could bring in terms of connecting people with their memories, finding clips, finding the steam train that they used to drive and the place that they were born in. It's got an incredible way of being able to connect older people with their personhood. When pandemic hit, we weren't able to deliver our normal sessions, obviously face to face, and we had two choices: one, to stop, or two, to find another option. And we used Zoom very quickly to be able to deliver those sessions to older people. But it was a struggle for care homes to begin with, because they were dealing in the midst of the pandemic. And to deal with technology was something that actually for a lot of care homes, it wasn't the right place for them to do. But after a few months, a few of them came on board and were able to engage. And as you can see here, we've got Irene with a huge grin on her face. And she couldn't quite get, to begin with, the fact that someone in the TV was talking to her and that she could talk back, and that Nikki was able to play her favourite music and talk to her about her history and her ideas and her opinions. And so we were able to deliver some sessions within care homes. We had hour-long sessions. It would be a facilitator-led. We'd use guided reminiscence and variety hour, small or large groups. It was the iPad generally that connected the TV, and it would be small groups generally around the TV that worked really well. But of course, there are challenges when you're dealing with technology in care homes. Often the staff aren't quite as techie maybe as we would like them to be. Often there were issues with Wi-Fi. Some care homes didn't even have it, so we couldn't go there. Some it would cut out at the beginning. Some staff didn't actually want to do it or found it really hard. And actually they were dealing with staff turnover and reduced staff numbers. And then gradually we found, actually, as we've said before, that a lot of older people were dealing with Zoom fatigue, that there's often the sessions were too long and it was difficult. So so after speaking to many of the care home workers, they said, what we do is we want your activity, but we need it at a time that suits us, that we can deal with. So what we did was we came up with an idea of producing our activity online so care homes could access it whenever they wanted it, and a live on demand was born. So this is now a subscription service. We've been able to develop it through funding. And we now have a dementia-friendly video platform that's suitable for people with dementia, and that's also suitable for people who are very cognitively able. We've got over 200 videos of bespoke content. It's searchable. You can look for your favourite presenter, you can look for your favourite style, you can look for it all. So everyone can actually be person-centred and find material that's suitable for them. We've been able to develop a range of content. We've spoken to older people as to what they want. So we've got quizzes, we've got reminiscence, we've got storytelling, we've got art appreciation, gardening, nature, exercise. There's a whole range of videos that suit different people. But what we've tried to do is to ensure that actually all levels are catered for. So we've filmed on 2 levels. We've filmed on a sensory level. So for example, we've just filmed in the Bluebell Woods, and we've got the most stunning footage of bluebells, of nature, of some really close up of some insects. So people can find that and be relaxed. But we've also got some really interesting and I suppose challenging a tour of Bath. We've got a tour of the Underfall Yard in Bristol, so people can really learn and share. And some of our reminiscence are what they're designed to do is enable people to really tell their stories and to be able to talk about what they're seeing. Some of the tours will be familiar to you. For example, we've got Ashton Gate here. So we've had quite a lot of fun. We've been to St Mary Redcliffe, and that's my old school church. So it was amazing to be able to link up my school with the work. Live on demand is available on multiple devices. So for example, a care home, you could have it on 5 devices in one go, but you can use it as a group. It's designed to support carers at home and in a care home to facilitate sessions. So you can do reminiscent sessions and pause and ask people the questions, so you can actually hear about them and hear about their life. It really sparks conversation. It's not designed to be passive. One thing that we've always been really passionate about at Alive is that our work enables older people to engage and to be able to tell their stories. So that's a little bit about how we've been able to develop our technology. It's available. If you're interested, we can send you a little bit more, and we can send you a link and we'll be able to share some of the videos and things that are on there. But I just really want to thank you for your time. It's been an incredible journey for us over the last couple of years, and we're really proud of what we've been able to achieve and still link with older people. So if you have any questions or any ideas, please get in contact, and I'll leave you in Ben's capable hands. Thank you.
Thank you, Isabel. Ben, please pass on our thanks for a really exciting presentation. And yeah, I agree. Fabulous project, or several fabulous projects there. Obviously, doing some fantastic work. So that's our 2 presentations. So we've now got some time to open up for general discussion and questions for our 2 presenters. So we've got Ben Trowell representing Alive, and Ellie, of course, our first speaker. So there were a couple of questions in the chat box, Ellie. Do you want to tackle a couple of those, and perhaps if you could read the question out first?
Yeah, just let me scroll up a second. Jill's is the first one, isn't it? So Jill asked, do I think that the emphasis on emotions is a natural inherent part of the care worker's role, positions care workers non-professional, or risks deprofessionalising the role? In short, yes. I think it does. I think this is, I mean, it's a much wider problem. It's something that we see in academia. It's something we see across lots of different jobs, that basically emotions-based elements of work are seen as female and are seen as naturally female, and as something that isn't rewarded in the same way, basically. So I think a good first step to kind of, I mean, there are lots of calls to professionalise care work, but I think a good first step is to stop viewing these things as natural, because they do involve skills, they do involve effort, And it is hard work maintaining a smile all day when you feel rubbish or when you're overworked. So I think it's kind of recognizing that and helping care workers to see that rather than manipulating through training and making out like these things are natural. I think that would be a good first step towards professionalizing. And you can see the kind of distinction when care workers talk about their work. So for example, they'll emphasize the importance of kind of giving medication and the more kind of technical aspects of the role. And those are also aspects of care work that tend to be paid more. So for example, you might get an extra 50 pence an hour if you're trained in medication giving, but you don't kind of get given anything extra for the emotional elements of the role. And quite often these things are unpaid as well. So things like attending funerals or helping family members outside of work are deprofessionalized at the moment. Does that answer your question, Jill? Where's the next one? Oh, Phoebe's, any sign of care workers mobilising as a labour force? I completely agree as well. I hate the phrase the second paycheck. I noticed I used it loads through that presentation, but yeah, definitely not one to kind of encourage at all. I think there are some signs. I think not many care workers have mentioned being unionised when I've asked, but I think there are some signs that care workers' frustrations are starting to kind of promote a bit more action. But I think it would be good to see a little bit more and hopefully people kind of mobilising rather than leaving. But I think it's a really hard one because of just general overwork and care workers not wanting to have to think about work outside of work, which I found also with recruiting care workers to interview that actually most people don't really want to kind of focus on work after they finished at the moment. So that's a really tricky one. Sorry, I'm reading and talking at the time.
I've got two questions, one for you.
Oh yeah, go for it, Paul.
I've got one for Ben. I'll put this question to you first, Ben, for you to think about, and we come back to it. It's about the move towards online intervention and support, or not support, online practices in terms of fulfilling those or maintain those intergenerational connections between children, young people and people in care homes. And so my question is really whether you see Alive as retaining some of those online elements, or is it about trying to find a blend or a balance? What's the kind of way forward? I could let you think about that if you like, and then I'll come back. I had a question for Ellie too, and I'll put it to you, to you, Ellie, to think about as well. It was really fascinating about that language about care workers treating people as though they're your own family member or mother. And as you were talking about that, I was thinking about what would I expect if I was in a care home and I was receiving care. And I'd want people to have kindness and compassion towards me, but I wouldn't want them to think about me as a family member or as their parent or grandparent, because I think there's a whole lot of assumptions there. And so I just wanted you to maybe reflect on what you think is happening there when people use that family metaphor. Is it about conflating it with qualities like compassion or kindness, or is it about projecting something else that perhaps is not so helpful to that relationship? So maybe if I come back to you, come to Ben first, and I'll come back to you to give you a little bit of thinking time. Ben.
Yeah, thanks, Paul. Really good question, actually, and something that is very open for discussion. And we've put it to all of the people that we work with, and we are getting mixed responses. Certainly, we will be looking to continue using technology. It definitely doesn't replace face-to-face engagement. I don't think you ever can replace the sensory element and physically being there. And obviously, as Ellie mentioned several times, you know, the touch and hugging and physically being there. That being said, there are lots of benefits to technology. It takes less time, so there's no travel involved. Lots of the forums that we run, we've gone digitally as a response to COVID. And actually, the majority of people have said they would prefer them to continue virtually, or at least a hybrid model, because they can take an hour and a half out of their day very easily. Whereas if you chuck half an hour travel each side, sometimes they then can't do that. Again, as Isabel mentioned, it's worked with some people and hasn't with others. One thing that we just didn't think about when we were setting all of these up, it was totally a COVID response, and it wasn't a direction we ever thought of going into. But very simple things like how your tech's actually set up. So having the screen and the speaker underneath wasn't something that we thought about. Lots of care homes were having the screen and then the speaker sort of a meter or a couple of meters away, and residents would get confused and they'd be looking at the speaker rather than at the screen. Isabel did mention as well, it took some getting used to of having people being aware that they could talk back to the screen, and it was actually directed at them and the questions were directed at them. But yeah, there were some hiccups at the beginning, and like I said, it didn't work with everybody, but yeah, it certainly was a way to remain connected, and we will be, to answer your question, we will be looking to continue as a hybrid model, but it certainly cannot replace that face-to-face engagement.
Thanks, Ben. I think that's a really important point about not fully replacing or not being of equivalent quality. Okay, thanks. And Ellie, if I come back to you. So this family metaphor, is it problematic? Should we be worried? Is it beneficial?
I don't think it's beneficial. I think it's probably, I mean, in some cases, I think that it's pushed and exploited probably quite actively, because it will cause care workers to kind of give up more time for their jobs. But I think a lot of the time it's just a phrase that people say, and that we really should stop using. But it's like that phrase people say, oh, men should treat women like that it's their own sister. It really reminds me of that. And that kind of, well, no, you should treat people like human beings because they're human beings. You don't need to pretend that they're your relative. And I think, I mean, there's so many problems with that. I'm going to end up just listing problems with it rather than solutions. But also this thing that actually you don't always have to like the person that you're providing care to. And sometimes that's not possible, but that shouldn't lower your standard of care. And I think by saying you need to feel like someone's your family member, that's kind of, that will cause a lot of problems in that sense. But also, not everyone treats their family members very nicely either. It's really idealistic to suggest that caring relationships in families are positive ones that we should always aspire to. Sorry, Paul, I forgot your question. See, I just listed lots of problems with it. So no, we shouldn't go for a family model. But I think we need a better language to replace that with as well. I think that that needs a bit of work, kind of thinking about, I mean, we've got person-centered care, but I think quite often care workers kind of have set phrases to kind of talk about and think about that as well, you know, put the person at the centre of what you're doing. And you think, okay, well, what does that actually mean? So I think it is an area that needs more work, but if it was up to me, I would completely eliminate all discussion of basing paid care work on the family model.
Thanks, Ellie. And I think this ties into the question from Hilda about Hilda's question about what do we mean when we talk about good care? What should good care look like? And what kind of language should we use to convey that?
Again, I really don't have a clear answer, but I think a good starting point is to think about care that is positive for both person receiving care or in need of care and the person who is providing that care, thinking about both, thinking about it as a relationship rather than something that's just one way. But I think it also depends on circumstances. I think, like you said, Paul, you know, that you, if you were receiving care, would want, you know, you wouldn't want someone to base that on a kind of family relationship. But it's different for everyone, isn't it? It's different. What people want is very different, which I guess is what person-centered care is getting at. But I think there's no kind of one size fits all, but a good starting point would be thinking about the needs of both parties in that relationship.
Yeah, and a really interesting point you make there about being a two-way relationship. It's fantastic. Okay, there's a comment from Phoebe in the chat box, and a question. I just wondered, before we turn to that, do people have other questions for Ben in relation to Alive's work and Isabel's presentation, or for Ellie? You don't have to put in the chat box, you can just turn your camera on and wave at me. I can see everybody's boxes now, so I won't miss anybody. Okay, Phoebe, would you like to speak to your comment or question if you feel comfortable turning your camera on?
Yeah, well, it's just really fascinating research, Ellie. It's been lovely to catch up with you. I was just sort of reminded about, I've done work on development workers, again, you know, a kind of caring, civic-minded sort of profession. And I just, you know, I just want to just comment really that what a fine line it must be between essentializing, you know, I'm a caring person and so forth but then, you know, materially, I know some people who are more caring than others, and have a kind of authentic caring attitude. And there's this concept of the wounded healer identity, a kind of white savior as well. You know, and I was just making a kind of comment really about, you know, what is it that draws people into care work, or more kind of compassionate services, if you like. That's all.
Yeah. I can't really say very much based on this research, but I know that a lot of care workers that I've spoken to through different projects have been carers for their families, family members or other people before they've come into paid care work. And often they've come into paid care work after the loss of that family member. So you can see exactly how that kind of model does work in training, because a lot of care workers can get how you would provide care to a family member, and then kind of their plan is to carry on doing a similar thing. But obviously it's very different when you then have a whole care home full of people to care for. So I guess that is a bit like the wounded healer thing. A lot of care workers have spoken about this kind of desire to care that has nowhere to go once they don't have someone to care for at home anymore. Yeah, sorry, I haven't really answered your question either, but it is fascinating.
And Rachel's made a really interesting comment there. Rachel Shermer, emotional safety is really important for both carer and cared for. Rachel, I don't know if you want to say anything more about that.
Hello. Yes, I hadn't planned to say anything, but I'm coming at this. I'm a music therapist, actually. I'm coming at this not as somebody who's a sort of carer within a care home environment, but I know certainly within the work I do, I would be expected to have supervision for my relationships with the people I work with, in terms of working out what's my stuff, what's the people I'm working for's stuff. And I think if you're going in with this baggage of blurring boundaries and not knowing, blurring the boundaries of what's family, what's work, what's your relationship with people, it can be really problematic. And I think for both parties involved, because I think these things are really quite complex. And having an opportunity to unpack those thoughts and feelings, and just sort of know what's your stuff, what's other people's stuff, is really important. But I don't know, I was quite surprised sort of listening to the talk that there is this family model and people are encouraged to see people as their own family. I understand empathy and care and open-heartedness, but this seems a step further and a bit messy.
Yeah.
I don't know if that makes sense.
No, it makes complete sense. I think that part of the problem, so part of that wider project was looking at, well, when were care workers encouraged to view their work in a kind of economic sense, and when were they encouraged to view it in this kind of family, emotions-based, non-work sense. And like one of the things that really struck me was that when a resident did die, care workers wouldn't be able to go to their funeral unless it was their day off. So they were encouraged to see people as family members, but as soon as it meant that they wouldn't be able to work a shift, it was sort of this click back into, well, actually, this is an employment relationship, so you need to be caring for the other residents now, not going off to someone's funeral. So it was all up to a point, and then when it wasn't convenient for their employer anymore, that was when it became really obvious that it was really
so where's the opportunity to process that grief and work through that?
Mm-hmm. Yeah, it just wasn't really there.
Thank you, Ellie. Thank you, Rachel. I'm just going to come back to Ben and to Alive. There's a question from Hilda. So Hilda, I'm just finding your question again. Here it is. So Hilda says, Ben, I was curious about what led up to the intergenerational model presented by Isabel. So what were the kind of events behind it, and were older people involved in that process? Or how were older people involved in that process?
Okay, yep, I hope I've understood the question right. So in terms of research for the project, we've, like Isabel said, we've been doing intergenerational linking for over 8 years now on various projects. Again, as it's been mentioned, it's not one size fits all. There are residents that say, I've done my time of, caring for children, and I've raised children. Why would I want them to come into the home? But there's overwhelming research, and from our evaluation and our feedback, it lights people up. It has been difficult over COVID, as Isabel mentioned in her video. You didn't get as meaningful relationships formed. It's so lovely to see some of the friendships that are formed and things that actually maybe wouldn't naturally occur without these intergenerational projects. In terms of the One Good Turn project, that came about solely because it was really hard to get people to commit. So what we would normally do is we would ask for schools to commit to a school year. It was really difficult to get people to commit to that longevity. I'm sure you can all appreciate it. We were all working day by day, week by week. You never knew what the following week was going to bring. So the idea of the One Good Turn was literally one good turn. So you were doing one good thing that could put a smile on somebody's face. And we actually found that sort of structuring it like that, we then ended up with people wanting to come back because it wasn't a commitment. They could then commit to another One Good Turn, and they actually ended up staying with us for the entire project, and are still with us now. So I hope I have answered that question. Hilda, do you want to add anything?
I think Hilda's having some connection issues. Hilda's actually overseas, so doesn't make it quite straightforward. Hilda, if you want to chip in, please do. Otherwise, Ben, I'll turn to Lois. Lois, you had a question. Do you want to ask Ben directly, Lois?
Hi, Ben. Yeah, it was just I research intergenerational programs for my PhD, and I'm really familiar with the work of Alive. It's really fantastic, and yeah, creative stuff that you've been doing as part of the Care Home Fans project. So it was really nice to see that presentation and overview of all that you've been up to. I was just struck by what Isabel was saying about some of the challenges and the importance of the staff in kind of facilitating some of the activities that went on, and just in terms of this broader discussion about care work and care workers' role. And I just wondered if sort of training or kind of that facilitation is part of Alive's work in terms of your interaction with care staff, or whether it's something in the future that would be something you'd include as part of your intergenerational work, recognizing the importance of those that facilitate within the homes or within schools even.
Yeah, absolutely. So we do intergenerational training, and we did that pre-pandemic, right at the start of lockdown, because Alive on Demand was born by myself and a colleague, finding out we were going into lockdown, and this was when we thought we were going in for 3 weeks. So we were like, oh no, we're not going to be able to go into the care homes. What can we do? So we just ran around with a video camera and a dictaphone from other projects that we knew residents wanted to visit. So we went to sort of St Werburgh City Farm, Botanical Gardens. We interviewed a farmer. Very, very low budget stuff, and we just sent it over to the care homes, and got such good feedback that that's where Alive on Demand was born. But yeah, to answer your question, there were definitely challenges. So we ran training courses every fortnight, totally free, just to teach people how to use basic tech, how to connect an iPad or a tablet to a TV, how to make Zoom calls and FaceTime and things to keep residents connected with their family. In terms of facilitation, it's absolutely critical that there is a facilitator there. We did do one session with a care home that the activity coordinator left the room, and it was 3 residents on an iPad, and the iPad fell down, so all the facilitator could see was the ceiling, and she couldn't convey to the residents that they needed to prop the camera back up. So it was about 20 minutes of one of our facilitators saying, hello, is anybody there? So yeah, they definitely still do need to be facilitated. We do provide training around that. I do think after 2 years, basically now, most people are relatively tech savvy with the basics. But yeah, they definitely still need to be facilitated. And the whole Alive on Demand subscription service as well, that isn't to replace engagement. It's all designed to sort of spark conversation. So the idea isn't you pop something on and leave the room. It, like is mentioned, so the guided reminiscence and the guided tours, questions pop up, and there's a little pause button. So you actually don't need to be trained in activities at all. But it is just to evoke and spark conversation, and also for those living at home. It can be very difficult, particularly from diagnosis, if you're not aware of dementia and you're not sort of aware of what's coming. Sometimes we find it's easier just to ignore it and just not broach the subject, whereas the idea of Alive on Demand is you can comfortably put something on. So like it's mentioned there, it's all filterable, but you can search by keywords as well. So if you know someone's into football, just type in football and that'll bring in any related videos. Yeah, and all designed to spark conversation.
Sounds great. Thank you.
Thank you.
Thanks, Ben. Thanks, Lois. I'm not seeing any more questions in the chat box. So if anyone does have a burning question, just in the nick of time, Phoebe. Another rhetorical question. Can we imagine any other professional industry relying on or exploiting the second paycheck? Surgeons, for example, or estate agents? Well, I'm saying probably not, but you might, I don't know if that's your view as well, Ellie. Oh, Ellie said, don't get me started again, Phoebe. Okay, we'll move on. But I mean, we jest, but I think this is a really important discussion about the language and the meaning attached to language that we fall into the habits of using across social care and care industries. And Ellie, your presentation is really insightful in giving us a deeper understanding of what that care relationship looks like and trying to get beyond some of that dominant or popular language. and helping us to understand, well, what are the qualities that we're trying to talk about here that are important to a good caring relationship, and what are the conditions around that relationship that help that relationship flourish. So thank you for sharing that really interesting research. And Ben, the work of Alive really brings alive, if I can use that cheesy pun, some of the fantastic work that's been going on during the COVID pandemic, and both before the pandemic and during the pandemic. And it's a really exciting space to watch in terms of where Alive goes next with some of this work. So thank you both. Thank you for everybody for joining us today. It's great to see this level of engagement and people's involvement in the forum. And we will have a summer forum in the summer months, and we'll get back to people shortly over the coming weeks through the mailing list with the date of our summer forum. And we're also in a discussion about trying to have an in-person forum this year. So fingers crossed, we can have one of these forums this year in person. And Jen, am I missing anything else vital that I need to convey?
No, but Louise does have a hand raised.
Oh, right. Beg your pardon. Louise. Hello, Louise.
Hello, Paul and everybody. I've not attended this network before, so it's been lovely. Thank you very much for inviting us from Bath. We're not in the Bristol area, well, close by. It was a general question about the network. So it's got that Bristol focus you were describing, but does the research work that's undertaken expand beyond that in order for there to be messages for Bristol and beyond, or how does that work? I just wasn't sure what the kind of remit was.
Sure. The forum is very much has a Bristol story in terms of its origins and in terms of the 4 organisations involved in its planning and delivery. But every forum we have speakers who are doing research in ageing, social gerontology, areas that cut across in relation to health sciences and social sciences that are relevant to issues about older age. So very much each forum we do have speakers whose research speaks to a broader, often England, often UK context that would have definite relevance to across care sectors in the UK and in England, not just Bristol specific. We try and find the right balance between broader research presentations with some more local work that's happening, so we can bring to life and showcase some of the great work happening in the Bristol area. But I think I could safely say we're open to showcasing great work happening with older people across the Southwest region. So if you are aware of some fantastic work, some important work happening with older people in the Bath area, for example, let us know, because it'd be great to have that wider involvement.
Okay. I suppose slightly, I was interested anyway, but there is behind my question also, I'm particularly interested in the role of activity providers in care homes, and they differ, I think, from the care worker group that Ellie has been talking about here today. And I'm looking to put an NIHR application together, focusing specifically on activity providers, their role within the workforce. So if any, obviously, Ben, I think that, you may well be, Alive may well be interested in that, but if anybody else is interested in having a conversation about that, then please do get in touch. I'm on the University of Bath webpage, is Louise Brown. Thanks.
Thanks, Louise. And if you want to email me, just a short email, I can share it with the planning group as well.
Brilliant. Yeah. Thanks.
Okay. Wonderful to hear about that. It's great for this forum to be involved in developing research as well, of course, as well as hearing about current research. Okay, wonderful to see everybody. I hope everybody enjoys the rest of the day. You'll hear from us soon about the next forum and the next theme that we'll be focusing on. Thanks all. Take care.